Welcome back, dear learners. Today we will see about the assessment of nutritional status of the population. So, what do we mean by nutritional status? Nutritional status is a condition of the body and it relates to consumption and utilization of food. The nutritional status of a person was defined by George Charles Takes as health condition of an individual is influenced by his intake and utilization of nutrient determined from the correlation of information obtained from physical, biochemical and dietary studies. Nutritional status of a person may either be good or poor. Now, good nutritional status, it refers to intake of a well balanced diet which supplies all the essential nutrients to meet the body's requirements. Such a person is said to be receiving optimum nutrition. The signs of good nutritional status of an individual are reflected by shiny hair, smooth skin, alert expression, clear eyes and a well developed stature and firm flesh. The person must be of correct body weight in relation to height. His responses should be normal and has a sound sleep. Good nutritional status is also reflected by stamina and resistant to disease. It may increase the lifespan of a person. In short, a person with good nutritional status can enjoy life fully. Now, nutritional assessment can be done in the communities, which is a preliminary step for formulation of any public health strategy to combat malnutrition. The nutritional assessment is a systemic process in which the state of nutrition and health of an individual or group of individuals is determined. The goal of nutritional assessment of communities is to discover facts about nutritional situation and guide action to improve the health and nutrition. The principal arms of nutritional assessment of a community are to map out the magnitude and geographical distribution of malnutrition as a public health problem, to discover and analyze the ecological factors that are directly or indirectly responsible, to suggest appropriate corrective measures not only for the control and eradication of malnutrition, but also for subsequent food nutrition. In addition, factual evidence of incidence of malnutrition in the community and of its often complex factors is needed in order to make the public and especially the fund controlling administrators and politicians to realize the extent of problem and so ensure financial support for such preventive programs as may be required. So, the major objectives of nutritional assessment are to determine the type of malnutrition, which says what, and to quantify the magnitude of prevailing malnutrition, how much, and to identify at-risk groups, who are the required people, and to determine the contributory factors, why this condition has come. In short, nutritional assessment of a community should aim at discovering the facts and guiding action intended to improve malnutrition and health. Methods of nutritional assessment can be assessed by the following types of methods. We have both indirect and direct methods, where the indirect methods include vital statistics and ecological factors assessment, and the direct methods include A, B, C, D, which include anthropometry, biochemical and laboratory estimation, clinical examination and diet survey. We start with the indirect assessment of method of nutritional status, starting with the vital statistics. What is vital statistics? So, this vital statistics are the important data or numerical information concerning the vital events of human life such as birth, illness, marriage, migration and death within the population. Malnutrition influences morbidity rates for various diseases, both maternal and perinatal mortality rates, life expectancy and other health statistics. A variety of vital statistics may therefore be considered as indirect indicators for the nutritional status of the community, which include age specific mortality rates, morbidity and cause specific mortality. Morbidity data can be collected in relation to protein energy malnutrition, anemia, xerophthalmia and other vitamin deficiency, endemic goiter, diarrhea, measles, parasitic infestations, which will provide information about nutritional status. The useful records kept by the government and various other agencies can clearly show the relationship of nutrition and health problem. Now, tools like birth certificates, marriage registry, immunization cards, death certificate, etc. can directly and clearly show the condition of the country where it is. If we see the development and assessment of nutritional deficiency, you have primary nutrition deficiency and secondary nutrition deficiency. So, if we see the primary nutrient deficiency, we have inadequate dietary intake. So, this can be seen by the dietary history. So, where we conduct the diet survey, and the secondary nutrient deficiency is because of the poor nutrient absorption, impaired nutrient utilization, increased nutrient excretion, impaired nutrient transport, nutrient destruction and increased nutrient requirements. So, this again goes to the reason for the primary nutrient deficiency. So, there is a gradual decrease in the tissue and the level of nutrients in the tissues. So, this can be known by analysis of blood, urine and tissues for nutrients, which can be done by the biochemical assessment. And this analysis of blood, urine and tissues for alteration in levels of enzymes and metabolites can be assessed whenever there is biochemical lesions. Analysis of blood, urine and tissues for alterations in levels of enzymes and metabolites will indicate biochemical lesions and which lead to anatomical lesions, where we can see through the clinical evaluation by doing clinical examination and anthropometry. This is how the procedure goes for the various tests like A, B, C, D, as I told you, the anthropometry, biochemical assessment, clinical assessment and dietary assessment. Now, second method is indirect method is assessment of ecological factors. The human malnutrition is always an ecological problem, that it is the end result of multiple overlapping and interacting factors in the community's physical, biological and cultural environment. Ecological factors related to the etiology and prevention of malnutrition include conditioning infections. There is a synergistic interaction between nutrition and infection, and also the infection has an adverse influence on nutritional status and may precipitate in frank cases of malnutrition. The commonly associated infections that play a contributory roles in the malnutrition are bacterial like tuberculosis, whooping cough, diarrheal diseases and bacillary dysentery. Viral includes measles, parasitic include malaria, intestinal helminthes and protozoal includes amoebiasis. Then food consumption also has a role. It is obviously important to have as much detailed knowledge as possible of foods actually eaten in the community, both for assessing the nutritional status and also for discovering dietary factors that may need necessary modification. The food consumption of the country's population at a certain time can be indirectly estimated by food balance sheets or food disappearance data. It provides data on food availability and disappearance rather than the actual consumption. The food balance sheets prepared by the FAO of United Nations are based on the assessment of quantity of total foods consumed in a country imports, foods allocated for seeds and industrial purposes, animal feeds and wastage of foods. The net amount is divided by the mid-year population of that community, region or country and by the days of the year to derive average per capita consumption per day. So, per capita food consumption per day can be calculated by the foods produced, imported and left over from the previous stock in a particular year, the foods left over exported at the end of the year divided by mid-year population multiplied by 365 days. So, food balance sheet generally provides information as the foods at the country level. So, the strengths of this method are that it can give a total view of food supplies in a country and can be used for drawing conclusions about food habits and dietary trends within the country. Food balance sheets are valuable for planning international nutrition policy and formulating food programs. The limitation of this method is that is not very accurate method. The amount of food reported available for consumption may not be true. So, the cultural influences, knowledge of local cultural pattern is essential for success of any nutrition survey. For understanding the local etiology of malnutrition and for the ultimate implementation of any program aimed at improving the situation. The cultural influences such as food, attitudes, meal pattern and local concept of the causation, cure and prevention of disease, the general pattern of child rearing in regard to food, nutrition and maternal care along with local cultural pattern in relation to food production, animal husbandry and food storage are extremely important. Then socio-economic factors, the socio-economic circumstances of the community are particularly difficult to assess quantitatively because people are usually reluctant to reveal their income or wealth to the surveyor. But the socio-economic status of a family determines the food purchasing capacity and hence their nutritional status. It is convenient to consider socio-economic data relating to nutrition in their separate aspects rather than in combination, which include the social data including the population of the community, the family types, size, stability, spacing between children, education, housing and common amenities, kitchen where building, location, fuel, hygiene and sanitation, food storage, water supply, the latrine and sewage. Whereas the economic data includes occupation, family income, tangible wealth. Tangible wealth includes the land, livestock, modern facilities, etc. Then budgeting, where the expenditure on food, clothes, rent, fuel, electricity, education, transport, etc. and prices of foods, the shops and markets and seasonal variations. Then food production, the assessment of food production in a country or region has ultimately to be considered in terms of availability of production to families. all the aspects of food production and supplies are relevant to the assessment of nutritional status of the community. Among them, the most important aspects are family food supply, which include home produced, purchased, collected and seasonal variation. The farming methods, which include the traditional as well as modern cultivation methods. Land, including the tenure, area per family suitability, actual utilization, etc. Their livestock and fishing, finance and distribution of foods, transport, storage, preservation, processing and marketing. Then health and educational services. Good nutritional status is somehow related to the levels of health facilities and educational services exist in that community. The following information regarding health and educational services are useful in indirect assessment of nutritional status. Health services, the full information if possible should be gathered on the following points. General, the number of hospitals and centers, distribution, number of beds, record keeping. Admissions in terms of number, age groups, diagnosis, prognosis, results of treatment, the mothers admitted with children, maternity admissions, etc. Then the outpatient record including the number, age group and diagnosis. Then follow up system, whether there is home visiting, and staff, which include the number of doctors, medical assistants, nurses, midwives, paramedical staff, housekeeping staff, etc. Then the infrastructure for the health includes wards, outdoors, laboratory, offices, kitchen accommodation, facilities for patients, parties and medicines, food and nutritional rehabilitation centers, and educational facilities which include school, children with the number, type, distribution and the attendance in school and nutrition education. For young people, clubs, young farmers, scouts, etc. And whereas for adults, the literacy, parent teacher association, clubs, etc. And with the mass media is another important education facility which include the radio, press, television and internet. Now, it is evident that any assessment of ecological factors in the course of a nutritional prevalence survey must vary greatly in complexity depending upon the type and number of staff, the time available and the purpose of investigation. This includes all the indirect assessment methods for the nutritional status. Now, coming to the direct assessment methods of nutritional status, direct assessment is more accurate method of assessment in which the individual is accurately measured, and it is usually done comparative for smaller population such that it is possible to assess each and every individual. In this type of assessment, certain indicators are measured on representative samples of the community to determine the nutritional status of the community, because the entire country population cannot be assessed. Direct assessment can be conducted by several methods, of which the most important methods include anthropometry, biochemical assessment, clinical studies and diet survey. So, all these are called as ABCD analysis. Today, we will see about the nutritional anthropometry. So, nutritional anthropometry is a tool that is concerned with the measurement of the variations in the physical dimensions and the gross composition of human body at different age levels and degrees of nutrition. So, this is based on the concept that appropriate measurement should reflect any morphological variation occurring due to significant functional physiological change. Nutritional anthropometry is an important component of routine nutritional assessment. It is used commonly in routine survey due to its simplicity, needs little amount of sophisticated equipment. Anthropometric measurements can help in the assessment of subclinical forms of malnutrition and has been recognized as a reliable tool to identify at-risk groups, monitoring changes in the extension of malnutrition and selection of beneficiaries for intervention programs, and evaluating the impact of interventions. Application of nutritional anthropometry. Nutritional anthropometry is a very useful tool and its application includes assessment of extent of undernutrition in vulnerable group of population, monitoring individual children at regular intervals, maybe monthly or quarterly, to find out whether there is any faltering in growth during the intervals and to help early detection and in initiating prompt remedial measures. Identification of children who are at risk of undernutrition to target and prioritize nutrition action programs so as to control the extent of undernutrition. Anthropometric measurements are useful in mid-term appraisal or terminal evaluation to assess whether intervention programs have achieved the objectives or not. It is also useful in assessing an individual's response to nutritional rehabilitation. Anthropometry can be utilized as a tool for nutritional surveillance and for collection of secondary data or indicators which may directly or indirectly affect the nutritional status. Now, it is used to assess the impact of seasonal variation of food supplies on the nutritional status of the community. This would also provide data on time trends when measured at regular intervals. Let us see the common anthropometric measurements. One of the most ultimate or unlimited number of possible body measurements. These measurements that are selected should be simplest and quickest to take and easiest to reproduce. They will give maximum information concerning the particular nutritional problem under investigation. The most commonly used anthropometric measurement used in a routine nutritional assessment include body mass as judged by body weight, linear dimension especially height, then body composition and reserves of energy and protein as judged by the principal superficial soft tissues, subcutaneous fat and muscle circumference. Circumference of head and chest are also important, which included in some surveys covering children under 5. For adiposity assessment, waist and hip circumference are also used along with fat fold thickness measurement. So, let us see each of the body measurement in detail. Body weight. Body weight is the mostly used and the simplest reproducible anthropometric measurement for overall nutritional status of individuals, especially for children. Body weight is a composite of all body constituents like water, minerals, fat, protein, bones, etc. and indicates the total body mass. The serial measurements of body weight in growing children gives a better index for growth monitoring. Its applicability is appreciated not only by health personnel, but often by less educated parents for whom it is useful as a source of health education. The evaluation of significance of weight measurements must take into account the length, frame size, proportion of fat, muscle and bone and the presence of pathological weight due to edema or splenomegaly. The body weight measurement should be combined with other appropriate measurements and with clinical examination. So, it should be a combination of anthropometry as well as clinical assessment. Equipment and techniques for weight measurement are: the choice of suitable weighing scale is vital to obtain accurate measurement of body weight. The weighing scale must be sturdy, inexpensive, easily transportable and accurate to within the limits, that is up to 0.1 kg accuracy. Weighing machines based on two different principles are available. One is beam or lever balance weighing scales and spring balance. The spring balance used in bathroom type of weighing scale, but it should not be used as it easily becomes stretched and inaccurate from frequent use. Salter type beam balance has been found to be reliable and is currently in use in most of the ICDS projects. Weight should be taken as far as possible with minimum clothing, without shoes and without holding any support. In case of infants and non-cooperative children, the weight should be taken with an elder person, preferably the mother, carrying the infant or child and subtracting the weight of the elder to get the correct weight of the infant or child. The zero error of weighing scale should be checked before taking the measurement and corrected as and when required. Mean 3 successive measurements will give the final body weight of the subject. Then the second important anthropometric measurement is taking the height, which also has a significance in assessing the nutritional status. So, the height or length of an individual is influenced by genetic or hereditary and environmental factors. The maximum growth potential of an individual is determined by hereditary factors, whereas the environmental factors like nutrition and illness determine the extent up to which the genetic potential is expressed. Inadequate dietary intake and recurrent infection reduce the nutritional bioavailability, resulting in growth retardation. During periods of severe nutritional deprivation, linear growth rate slows down, leading to stunting of an individual. So, when the individual is growing, if there is a illness in an individual, the growth stops there or reduces and stunting results. Since height is affected only by long term nutritional deprivation, it is considered as an indicator for chronic or long term malnutrition. Height is a very reliable parameter that reflects the total increase in size of the individual up to the moment it is determined. Equipment and technique for measuring the height: for older children and adults, vertical measuring rod or scale fixed to the wall can be employed. Standing height is measured by an anthropometer rods or stadiometer scales, whereas in case of an infant and early preschool children, recumbent length, that is from crown to heel length, is measured with the help of an infantometer. Here the infant is laid on a board which is itself on a flat surface. The head is positioned firmly against a fixed headboard with eyes looking vertically. The knees are extended, usually firm pressure applied by an assistant, and the feet are fixed at right angles to the lower legs. The upright sliding foot piece is moved to obtain firm contact with the heels, and the length reads to the nearest 0.1 centimeters. Whereas, in case of older children and adults, the subject should stand on a flat floor by the scale with feet parallel, with heels, buttock, shoulders and back of the head touching the upright. The head should be held comfortably erect with the lower border of the orbit in horizontal plane as external auditory meatus. The arm should be hanging at the sides of the natural manner. The measuring scale should be 2-meter high and capable of measuring to an accuracy of 0.5 centimeters. In case of non-ambulatory person, the height is measured by asking him or her to raise the hands sidewise, which will give the height of the person. This measurement is known as demi-span. Then knee height or ulna height measurements can also be used to assess the height of non-ambulatory patients. These measurements are known as surrogate measure of height. Then third measurement, important measurement in children under 5 is head circumference. The measurement of head circumference is a stand and procedure in pediatric, usually to detect pathological conditions accompanied by large head or one of the increasing size, as for example, hydrocephalus, where large of fluid is accumulated in the head, or too small a skull, which is called as microcephalus. Head circumference is related mainly to the size of the brain, which increases quite rapidly during infancy. Head circumference normally reflects the age rather than the health or nutrition. Head circumference increases rapidly during the first year of life, but it is slightly affected in the second year of life because of PEM, although much less, so that it is lesser than the chest circumference. In nutritional anthropometry, the chest head circumference ratio is of great value in detecting the protein energy malnutrition in early childhood. The head circumference may also be used as a rough additional guide in the age assessment. Equipment and technique required are: measurement of head circumference should be done with a narrow, that less than 1 centimeter wide, flexible, non-stretch measuring tape made of fiberglass. By placing it firmly round the frontal bone just superior to the supraorbital ridges, passing it round the head at the same level each side, laying it over the maximum occipital prominence at the back. Now, measurement should be made to the nearest 0.1 centimeters. Chest circumference: the chest is normally nourished. Child grows faster than head during the second and third year of life. As a result, the chest circumference overtakes the head circumference by about 1 year of age. Therefore, between the ages of 6 months to 5 years, a chest head circumference ratio of less than 1 may be due to failure to develop or to wasting of muscle and fat of the chest wall. So, this can be used as a community indicator of protein energy malnutrition in the early childhood. Now, the equipment and technique are a narrow, flexible, non-stretch fiberglass tape, and the measurement is made at the nipple line, preferably in mid inspiration, and the measurement should be made to the nearest 0.1 centimeter. Then another very important measurement is the mid upper arm circumference. So, which indicates the poor muscle development and muscle wasting, which are cardinal features for all forms of protein energy malnutrition in the early childhood. In older children and adults, muscle mass is calculated to general exercise and special increase use of certain muscle groups. Mid upper arm circumference and calf circumference are recognized to indicate the status of muscle development, but of the two, the mid upper arm circumference is considered more feasible as it is simpler and easily accessible at any age and gender. So, it is practical to measure. Between 1 to 5 years of age, the arm circumference remains fairly constant. So, it has been reported that mid upper arm circumference may be useful not only to assess malnutrition, but also in determining the mortality risk of the children. It correlates with the weight for height and clinical signs of protein energy malnutrition. When measured along with fat fold at triceps, the mid upper arm circumference in addition can be useful to calculate mid arm muscle circumference, assuming that the cross section of mid upper arm circumference approximates a circle and the adipose tissue is evenly distributed around the area. The instrument and technique here are: the mid upper arm circumference is taken on the left hand generally, and the midpoint between the tip of the acromion of the scapula and the tip of the olecranon of the forearm, both ulna and the arm flexed at the elbow at right angle and marked with a marker pen. The arm should hang freely and the measurement is taken using flexible non-stretching measure table made of fiberglass. The tape should not extend too much pressure on the soft tissue. The reading is taken to the nearest millimeter with the tape still in position. Reading below 12.5 centimeters indicates severe protein energy malnutrition, and 12.5 to 13.5 centimeters moderate protein energy malnutrition, and about 13.5 centimeters is normal. Recently 12 centimeters and 13 centimeters have been suggested as cutoff points for some studies conducted in Trivandrum instead of 12.5. So, it is 27 to 30 centimeters in adult women and 30 to 33 centimeters in adult men. Now, subcutaneous body fat measurement is the sixth measurement that is important. So, adipose tissue is widely distributed over a large number of sites in the body. So, subcutaneous fat constitutes the body's main store of energy reserves, and there is a close association between the fatness and calorie reserves, between muscularity and the protein status. This relationship can be used as a tool to assess gross nutritional status of the persons at specific stages of life. The subcutaneous adiposity is measured by a skin fold thickness measurement using calipers, and this is done in the nutritional anthropometry. Now, instruments and techniques are the skin fold thickness at all necessary anatomical sites like the scapula, chest, triceps, biceps, abdomen, thigh and suprailiac etc. can be conveniently measured by the skin fold calipers. So, various skin fold calipers have been devised, of which most often used ones are Harpenden calipers, Lange calipers and the USA mRNL calipers. These calipers used should have a standard contact surface, that is the pinch area of 20 to 40 millimeters and at an accuracy of 0.1 millimeters. It should exert a constant pressure of 10 grams per square millimeter throughout the whole range of skin fold thickness at all distances of separation from the jaws of the caliper. The techniques measured at different sites of the body are subscapular. The direction of fold should be diagonal and inferior angular of the subscapular region, and the fold is natural cleavage line just inferior to the inferior angle of the scapula. The calipers applied at 1 centimeters below the scapula. Then triceps is vertical midpoint between the acromion process of the scapula and olecranon process of ulna. So, just like the mid upper arm circumference, here the midpoint is measured and the fold is 1 centimeters above the line of posterior aspect of the arms. Then biceps vertical, and the biceps brachii. Skin fold is lifted over the belly of the biceps at line marked of triceps. So, calipers is applied 1 centimeters below finger. Thigh, again the measurement is vertical, midway between hip and the knee joints. The point is located anterior to the midline of the thigh, and chest, it is the diagonal measurement outside the edge of the pectoralis major muscle, just medial to upper armpit. The skin fold will run diagonally between shoulder and the opposite hip. Abdomen, vertical, which will be at the umbilical position, a point adjusted to the umbilicus is measured. And then there is suprailiac, which is oblique and at the iliac crest, and the fold is grasped behind the mid axillary line and above the iliac crest. So, these are in brief all the measurements that are required for assessing the nutritional status through the nutritional anthropometry. We will see the remaining types of the indirect measurements in our next coming classes. Thank you.